Okay, thanks everybody for your patience as we're figuring out some technical difficulties. It feels a little apropos to start an ADHD presentation not on the minute, so we'll roll with it. I just want to make sure that everybody's aware that if your viewing is anonymous, you can still receive your CE credits. Just make sure that you complete that evaluation form. That will be sent to you, and then I think we may also be able to drop that in the Q&A chat as well, so maybe check over there. And feel free to contact us if you have any questions. I want to just start with an introduction to kind of what my deal is and who I am. I'm going to move kind of quickly just with the late start to make sure that we can get through things. But I am trained as a school psychologist, and what that means is that I worked with a caseload between, depending on the year, ranged from 30 to 75 kids. Ages elementary and middle school primarily, and at any given time, about half of that caseload had ADHD. It was fairly uncommon for me to see ADHD by itself. More often, we were also talking about anxiety, depression, oppositional defiant disorder, and very occasionally bipolar. And so this is something that I've become pretty well acquainted with. I'm also a postdoctoral fellow and a licensed psychologist at the Utah Center for Evidence-Based Treatment. Through our assessment and testing program, we've created the Tackling Avoidance with Skills and Compassion, or TASK group, which is geared toward people with and without ADHD who are trying to figure out how to work from home or attend school from home during the age of COVID. And it is geared from self-compassion and CBT for ADHD. I also am a human with ADHD. This has been a part of me for as long as I can remember and is a really important piece of my identity. Doing this presentation is kind of interesting to me because I get to coalesce all of this information that I've collected as a professional, but as a human, I kind of get to come home and I get to share this community that I have a lot of passion about and a lot of affection for with other people. And then I'm an ADHD clinician, and what that means is that as a clinician, I have a really strong value of radical openness and radical genuineness. And so that includes disclosing that I have ADHD and that this is a part of me. This provides a number of different clinical functions. One is that I very often am the first or among the first to say, hey, did you know that this thing about you is really cool? Welcome to this amazing community that you get to be a part of. There's also a lot of shared experience that comes with growing up with ADHD. And so there's a lot that's said without being said. And then my entire dissertation was on observational learning. And so I feel very strongly that I need to model the behaviors that I want to see. And this includes self-acceptance and positivity and excitement around ADHD, as well as radical acceptance of the challenges that can come with it. So what is ADHD? And I'm going to, especially given where we are with time, I will warn you, I'm going to blow through this slide. This is the classic definition of ADHD as we know it, courtesy of the DSM-5, neurodevelopmental disorder with onset in the developmental period, presenting with 6 or more symptoms prior to age 12, impacting a wide range of areas. I do want to highlight social skills just because that's one that I don't hear talked about quite as often. Social challenges and delays are extremely common in people with ADHD. This is a developmental delay. Our brains mature more slowly, as far as the research can tell. There's some debate about when our brains are done maturing. I've seen everything from age 25 to 35. It depends on who you're asking. I often hear that this is a condition of childhood, and absolutely not. 80% of us are not going to grow out of this, and for that other 20%, we aren't sure about them. Maybe it's a misdiagnosis, maybe they acquire skills to reduce the impact substantially. We are not sure. And then a diagnosis secondary to the presenting problem. I very often hear ADHD treated as kind of a wastebasket diagnosis, but if you think about it, this is something that's been present with us from a very early age, often with symptoms emerging as early as 2 years old. And it's part of our hardwiring. It impacts every moment of how we experience the world. So how could it be secondary? Of course, it's going to be an integral part of what's bringing us to therapy and how we're experiencing the world and living our lives. So what is ADHD really? My coworkers will tell you that I never miss an opportunity to show off my dog, who you'll see in a minute. I'm just a dog person. This is something that I say very frequently to clients, which is ADHD is like having a collage for a brain when the rest of the world got a picture book. And when I say this in a room full of people, the people that I suspect are neurotypicals will make kind of a sad sound, and the ones that lean more toward ADHD are like, yeah, that makes a lot of sense, and they get kind of excited. So that's always really interesting to watch. But the idea here is that when we're working on a specific topic, whether it's in conversation or trying to solve a problem, there are a lot of images, memories, ideas, concepts, statements, anything that pop up all at the same time, rather than being prioritized and ordered in this fashion that you might have with like a book that has page numbers. For some reason, when I tell people my brain doesn't have page numbers, my ADHD clients are like, oh, me neither, that totally makes sense. And so this is something that I encourage people to kind of take in your conceptualization and look at, okay, is this one of the things that might be contributing to overwhelm? Is all of this stuff shows up at once and there's a kind of flooding that can occur with ideas and concepts? For many people, ADHD is a sleep disorder, and I am no exception. I'm pretty open about this as well. This also makes sense, right? If we think about ADHD and this idea that it's part of how our brains are built, we don't stop having ADHD when we go home from school or work. We don't stop having ADHD when we go to bed at night. It impacts us in a number of ways, or to the point that it's actually been a debate in a couple of iterations of the DSM about whether or not sleep disturbances need to be included in the diagnostic criteria. And this makes sense because when we think about ADHD as a disorder that includes difficulty sustaining alertness as well as activating, that plays a role in sleep. So whether we're having difficulty falling asleep because we're ruminating, we're seeking stimulation because we just have that infamous low boredom tolerance, or some challenges with circadian rhythm, there is some research to suggest that neurodivergents experience a different cortisol cycle or a more sensitive cortisol cycle than neurotypicals, and that can impact sleep. This also can mean our quality of sleep is impacted. We had a running joke in my family that was actually not a joke at all, where if I was traveling with my parents and my sister and we would get a hotel room, I was not allowed to share a sleeping space with anybody because whether I was dreaming or not, I would run in my sleep, which ended up, rapidly kicking the other person. And that was just how I slept as a child. This also can translate to difficulty waking up. This is one of the most common frustrations that I hear from parents when I do parent coaching for anywhere from probably age 7 all the way up into the late teens. One of the questions that came in was about integrating stimulant treatments with behavioral interventions. And this is where this shows up the most often, I think, is very frequently I will implement a behavioral intervention that facilitates the person taking their medication right when their alarm goes off. Even if they go back to snoozing for 20 to 30 minutes, getting the medication in their system makes it easier for them to start and continue through the morning routine once they get to that point. And that smooth start to the morning, or relatively smooth start, can make the rest of the day go a little bit better, largely because ADHDers have this infamous challenge with change and transitions. The other place that we see this is intrusive sleep, and this can sometimes even look like narcolepsy. This is the idea that we're suddenly and abruptly disengaging from a neurological stimulus, and research on this is actually suggests that when we disengage from that stimulus, there's this massive intrusion of theta waves. I have a lot of experience with intrusive sleep. I've been teased about it a lot. I can sit down to watch a movie that I'm excited about or a football game with a team that I really care about and just be completely out by the end of the first quarter. Then I get up and brush my teeth and go to bed like I never even had a nap. It's my superpower, is what I've decided. If there's anything that you take away from this presentation, though, I hope that it's this, which is that living with ADHD is stressful for a large number of reasons. Very often, to be really frank, I hear ADHD painted in the way of how it inconveniences the world around us or how it makes things hard, but then we don't take the next step and talk about how stressful that can be. And so we have these core features that contribute to that stress fairly directly. Like if we experience anger and anxiety really intensely, then it makes sense that we're going to experience more stress. Living with executive function deficits can be stressful because starting a task is hard. Knowing that you're struggling to start with a task is hard, and there's kind of this spiral that often happens. And then always late but worth the wait. I think we're worth the wait because we can be a pretty fun bunch of people, but we are frequently late for things. I do want to pause on this for a second because it's something that I hear referenced sometimes where a therapist might become frustrated that their client is frequently showing up late for sessions. I know the kind of classic characterization that has become a little bit less frequent is that that's like a form of resistance. But when I chain this with clients, whether it's, they're frequently late for work and they're wanting to change that behavior, or they're frequently late for session or whatever it might be, what we identify often is that there's the fear of boredom, which is if I'm late for if I'm early for something, I'm going to have to sit there and be bored. And that's the worst. But if I'm almost late for something, that's really stimulating and really reinforcing because I get that kind of stress and then I'm on time and it's like victory. Yes. But when that's kind of the window that we're living our lives in, we are obviously increasing our odds of being late for stuff. And so when we start to talk about in that context, rather than this judgment of like, I'm just late for everything, why can't I get my punctuality together? That's where I start to see some changes happen. There's also this really significant relationship with negative feedback that tends to occur. Research has suggested that ADHDers will experience peer rejection through their development about 40% more than their neurotypical peers. Sit with that for a second, 40%. There's also this added bonus, which is sarcasm, that we are wired for negative screams and positive whispers. And this is a human trait, I would say, but a lot of the characteristics of ADHD like this seem to be humanity amplified. So research around like our action potentials and consequence prediction suggests that we struggle to encode consequences. We struggle to predict consequences. So we're very bad gamblers. Don't take us to Vegas. And we have a real challenge where we anticipate negative consequences more frequently than we do positive. We also anticipate rejection more frequently than we do acceptance. And so that creates a lot of anxiety, as you would understand. There's also a strong relationship between symptoms and parent feedback, which I think has been established in some other disorders, like with schizophrenia, where if there's a lot of negative expressed emotionality between parents and child, that can worsen the ADHD symptoms in a way that medication can't touch. And so bringing a lot of warmth and repair in that relationship becomes a really crucial element of parent coaching, even if you've got the really strong behavioral focus. And then there's this idea of 20,000 paper cuts. And what I mean by that is this, that it's estimated that by the age of 12, a child with ADHD will experience 20,000 more corrective or negative comments from an attachment figure than their neurotypical peers. This is a lot of stress, and a lot of it is occurring by the mid-teens. So it makes sense that we get to this next point, which is that comorbidity is the rule rather than the exception. Here are some of the things that are established as being more common in the ADHD population. So teen onset bipolar 1, and I just want to be really clear, we are talking about the onset of an identifiable full manic episode within the teens. Disruptive mood dysregulation disorder, obviously oppositional defiant conduct disorder, those are pretty well established as being more common in this population. A couple of other things, OCD and tic disorders and ADHD, all have this relationship of dysregulated activity in the caudate nucleus. So if anybody has a giant pile of money and wants to do an fMRI, shoot me an email. I would be so fascinated to do that. Some other things that are really common, learning disabilities, which these also, if you see adult clients, are really, really important. I do a fair amount of accommodating in how I implement treatments around combinations of ADHD, dyslexia, and writing disabilities. Don't pay attention to this graphic as far as like the neuroanatomical messages. That's not what I want you to take from this. I want you to look at the healthy brain and the brain with ADHD. The alternative to the brain that I am currently living in is a healthy one. There's so many inaccuracies here. So just no. These graphics are really, really easy to find. So please be very mindful of your sources as you're working with clients on resources for psychoeducation. The negative messaging around this disorder gets perpetuated very, very easily. Now we have a distraction. This is my dog. I have a border collie, and raising her has taught me a lot about myself, and it's an honor to share some things in common with this lovely little creature. The reason that I chose that picture is because she looks like she's very excited to see me, but I'm actually holding a ball. That was her first snow, and she did not care because I had a ball. She was very, very hyper-focused. And that's something that I talk with ADHD people about a lot, is how we can find ways to harness hyperfocus to our advantage and how we can manage distractibility in an effective way. Some of these other features, these I kind of refer to as the softer features of ADHD, excuse me, where maybe they're not explicitly in the diagnostic criteria, although stimulus seeking is explicitly mentioned in the DSM. But these are really, really common features. If you're ever looking for something just super interesting, that strong sense of justice and fairness has some really lovely research. There's actually some correlation between ADHD and a sense of justice and the development of oppositional defiant disorder. Yeah, that's one of my favorite pieces of research, just because that oppositional behavior immediately becomes so much more complicated than it seems. And then we have this infamous low tolerance for boredom. And I kind of mentioned that in the, always late but worth the wait. There's some other ways that shows up as well. The idea here is that ADHD involves a high degree of stimulus seeking. And it makes sense that if we're driven to seek a lot of stimulation, we have a low tolerance for boredom. In Driven to Distraction, this is one of my favorite quotes. I share this with clients all the time. The most riveting stimulus is physical pain. Worry and anxiety are the mental equivalent. And this is not about enjoying pain. This is about pain is greater than boredom. And I will write it as a little equation on the board for my clients to look at. And it tends to resonate very loudly. And so then, rather than, moving toward like, why can't I just stop being anxious, we move toward avoiding being bored and finding other ways that they can avoid boredom that don't involve ruminating. Some other things to know about this low boredom tolerance and where it may contribute, especially in adulthood. ADHDers are 3 times more likely to have issues with alcohol abuse. And 22% of us are dealing with a substance abuse disorder. So things to be very aware of. There's also this relationship with borderline personality disorder that I find fascinating. 14% of us meet criteria, but in the BPD population, 38% meet criteria for ADHD and 60% met criteria in childhood. There's some really lovely research here about girls with ADHD who in their teens have a disproportionate number of office discipline referrals in school, are more likely to be diagnosed with BPD later in life. Again, if you have a pile of money, I would love to do a study. Some other things about us. I have this list of features here, and this is something that I do with clients regularly, is we start to look at which features are most prevalent in their lives and how can we hold those as dialectics, because so often things have been polarized toward the negative or the broken that we really we have to start practicing the skill of holding these things a little more lightly and in a more balanced and non-judgmental way. And this quote from F. Scott Fitzgerald is one of my favorite when I'm talking about ADHD. The test of first-rate intelligence is the ability to hold 2 opposed ideas in the mind at the same time and still retain the ability to function. One should, for example, be able to see that things are hopeless and yet be determined to make them otherwise. And while with ADHD, I don't agree that things are hopeless, I don't hold hope that I can rewire my brain, nor would I want to. And yet I remain determined to navigate a world that was not built for me. And that's a frank discussion that I have with my clients. And so I don't want to spend too much time on this, just to make sure that we get through the rest of the presentation. But I do want to encourage you to take a moment to look at these features and think about where might the positive and the challenge lie. Cognitive rigidity is one of my absolute favorites. I love working with neurodivergent clients because of this rigidity and concreteness that we have, where yes, it can make things more challenging. And we run into things like justice, where a lot of my clients just dig their heels in on, no, the world is unfair and I want to make it better. There's no talking them out of it, and I love it. So I want to get into things that I hope can be clinically helpful with this population. First is a note about notes. If you have enough data to support it, please put this diagnosis in the chart. Accessing medication for ADHD can be a real challenge. And so if that diagnosis is established, helping the client to have one more piece of the paper trail so that they can refill a prescription that they can only have a month of at a time in Utah, that can be really helpful. I understand why the regulations are written the way they are. And the challenge here is that the medication for an executive function deficit requires a lot of executive function to access. So if you can be helpful, do. There's the paper trail right there. The other piece is to validate and remind yourself. So if you're feeling stuck and running into some frustrations or find that you're having to repeat yourself a lot, when that diagnosis is in the chart and you go through to do the note and see it, that can actually be really helpful for you of like, oh yeah, I might need to repeat myself. This doesn't have to be a thing. This is just part of what this person needs. And then that reminder that ADHD is no small matter. It's a huge part of the whole person that you're treating. Even if they're coming to you for OCD or any other non-ADHD diagnosis, it's still a factor in who they are. Assessment is another area where a lot of questions tend to arise. I just want to validate it's okay to consult and refer. This diagnosis seems simple. I think there's been a certain amount of minimizing that's happened that is starting to go away about how difficult this diagnosis can be to identify. So I really just want to validate that. As far as best practices in assessment, we're really moving more in the direction of a comprehensive evaluation that includes neuropsychological measures. And that can create some access issues, but if the client is able to access it, I tend to be pretty encouraging about it. These are just a non-exhaustive list of ideas of when to refer. A couple that I think we underestimate the value of assessment, or at least I find myself doing that at times, or when treatment is stuck. When I've had colleagues who have very kindly reminded me like, hey, an assessment might be really useful here, that has absolutely been what's gotten us unstuck. So just, I don't know, a few ideas here to be aware of. Also, one note here, if they're looking for accommodations for school or workplace, and this includes college students or tech school students, they typically are going to require a formal evaluation with very specific parameters. And so coaching the client through that process of even just finding out what those parameters are and which practitioner is going to be able to perform an evaluation within those parameters, that can be really, really valuable to your client. Some treatments for getting started. First question is, are you treating the ADHD or are you treating the person with ADHD? Which, not that you can separate the two, but what's the target of treatment? If we're talking about ADHD symptoms, then behavioral interventions are pretty well established. This includes behavior planning. And I teach people to work their own behavior plans and implement their own reward systems. Visual supports are also really, really crucial. With this idea of the collage brain and that cognitive overwhelm that can happen, I frequently will talk to people about the eyeball rule, as I have called it, where we're trying to get as much information out of their brain as possible and onto the other side of their eyeballs so that they can physically look at it. That makes the process of making decisions and considerations much less overwhelming and much more accessible. Behavioral interventions like self-monitoring and video modeling or self-modeling, which involves having the person create a video of themselves and then editing out like off-task behavior, have been shown to be pretty effective for increasing engagement and on-task behavior, like in a classroom setting in particular. There are also several really great CBT curricula for ADHD. I will talk about some of the limits of those in just a moment. And then there's some emerging research that mindfulness can be really effective for dealing with attentional dysregulation, which just makes sense, right? The basic idea of mindfulness is that we're using our attention in a really intentional, targeted kind of way. And so to me, that almost feels like a replacement behavior when we're really struggling to stay on target with something. Mindfulness also has that really crucial non-judgmental element that I really appreciate, because again, if you're dealing with anybody really aged 12 or 14 and up, they've already accumulated a history of being told what they're bad at and that they can't focus. And so giving them this tool to build that focus and to be gentle and kind with themselves when they are finding themselves distracted, there's so much power in that. Now we get to other treatments where maybe you have somebody coming in for another concern, but they do have ADHD, or ADHD is part of what they're coming in for. I'm a big fan of all of these treatments here. It's much more about adapting and accommodating. One of the big ones that I think doesn't get talked about as much as I would like is expecting response latency. Especially in children, we found that children with disabilities, which would include ADHD, autism, learning disabilities, all of that, they need more time to process. And this means like 8 to 10 seconds after you ask a question. And so building this habit, and I know a lot of us have already worked on our tolerance for silence in grad school, but be willing to extend that when you're working with an ADHD person, because that's one of the other things that occurs in our history really frequently is we're asked a question, we don't respond quickly enough, and then we get talked over. And so we kind of just learn to withdraw. Keeping expectations or homework concrete, explicit, and visual. So ERP is one of my favorite examples here, where yes, we outline their planned exposures for between sessions, but we do it in a really visual, almost calendared and scheduled kind of way, and be really explicit about what SUDS level we're going for, because otherwise we can double down on the avoidance where yes, I'm asking them to do something very uncomfortable and non-preferred, but then they also have to plan out what the task needs to be, how it should look like, and remember what we talked about in session. And so just this very basic accommodation can make that treatment a lot more accessible. You may also need more repetition. This can kind of go back to that working memory overwhelm, as well as difficulty anticipating and predicting consequences. Visual supports, I will just beat that one into the dirt, because it's so important. One of the places that this can show up is like with cognitive processing therapy is a great example. It's a really lovely structured treatment, and sometimes the worksheets can be a little bit overwhelming. And so what I might ask people to do is fold one in half. And it's not that they only have to do half of it, it's that they're only looking at half of it at a time. And that just makes it more approachable. And then integrating psychoeducation and basic principles. It's okay to weave it into the treatment you're doing. So basic principles, since I said it, here they are. Get excited and make friends with it. It's very likely that you're the first person to say, hey, did you know this thing about you is really cool? Psychoeducation can feel too easy, but it's so crucial. I've had a number of cases with people ages 18 to 25 who I will ask them, what do you think ADHD is? And they will say, I can't sit still and I can't pay attention. And I'm like, yes and no. There is so much more here to be aware of. Some other things, the eyeball rule, like I mentioned, providing support with that history in mind. Very often when my ADHD clients come to session and have not done their homework, like for DBT or ERP, there will be a lot of shame. And so instead of really focusing on why didn't this get done, we'll still do missing links, but I really try to up the self-compassion and the compassion that I'm modeling quite a bit, and let them know pretty explicitly, like, I know that you're already punishing yourself. Like, that's something that we're working on, so why would I help you with it? Use a lot of novelty, irreverence, and humor. I do want to give a caution with humor, which is that ADHDers are used to getting laughed at, and self-deprecation is often adaptive for us. And so, yes, we love humor. Just make sure that you're using humor that does not feed into that self-deprecation. And then this last one, I think I already said this, but this is something I say frequently to clients. The world wasn't built for us, but we have to figure out how to navigate it anyway. And that's okay. We just get to find our own way of doing things. We don't necessarily, need to be mad about it or let it really get us down. We just have to find a different way to move in this world that we're living in. Another thing that's really important to understand is that the concepts of urgent and important are basically the same for a lot of us. This is an intentional skill that a lot of us have to learn, where something might feel really urgent because it's important to us, and so we'll prioritize it over something that is explicitly due maybe in an hour. And so I show the Eisenhower matrix to most of my clients. We draw this on the board, we practice it in session, and it can become a really useful tool. There are several different iterations of it, and it pops up a lot in the CBT materials. I like this version because it has the decision made for them. So that way we can outline these items in their respective quadrants, and then they look at the decision, and if it feels funny, maybe it needs to be in a different quadrant. This becomes very, very helpful. Some other things. Be mindful of that history-heavy language, and some of the assumptions that can come with this as well. Sorry, I have to take a deep breath for a second because I'm moving quickly just to keep us on time. And I have a lot of feelings about the word inattention. And yes, I am about to start an argument with the DSM-5. The reason for this is that we get told what we can't do, that we can't pay attention. And there's a lot of inherent judgment that can come with this term. And so I really try to reframe this as attention dysregulation. And I tell people, you are not a potato. You are not lacking in attention stores. This is not like a finite resource. It's that you're struggling to keep your attention on the thing that you want it to be in that moment. Let's work on that, which again is where mindfulness can play a really big role. And especially where a lot of clients are used to talking about emotion dysregulation in some capacity, framing attention in this way of being dysregulated rather than depleted ends up making a lot of sense pretty quickly. Another term that I have a lot of strong feelings about is procrastination. It also carries a lot of inherent judgment, and frankly, I don't find it to be that behaviorally anchored. And it kind of implies intent of like, well, I just chose not to do this thing, and I put it off, and I did a horrible job, versus what I hear the vast majority of the time when we really dig into what is procrastination. It's like, well, I kept trying to start, and I couldn't. Or I thought about starting and I felt really overwhelmed. Or I had a plan to start, but it just sounded so boring. And so we really dig into this idea of avoidance and what's driving it. Some others that show up, dramatic, I think is working its way out of the therapist vernacular, which I'm super excited about. I also don't have a lot of utility for this term. We are stimulus seekers, and we tend toward emotional dysregulation. One point that I want to make about this is that very often my ADHD kids, especially in that elementary to tween age bracket, tend to be the quote unquote pot stirrers in their families. And it's not that they're out to cause trouble or that they want to hurt anybody or make anybody angry. It's that having discord and chaos is really stimulating and novel and interesting. And so one of the most common quote unquote prescriptions that I will write is for exercise, whether it's a team sport or martial arts, something that helps to move a lot of that energy, provide a lot of stimulation and a lot of novelty and excitement. I find that when kids get involved in these activities, preferably multiple times a week, a lot of that pot stirring can go down. And then of course we combine that with behavior management and compassionate implementation of consequences and all of that. Non-compliance is another really huge one. I talked a little bit about the relationship between justice and non-compliant behavior, quote unquote. Very often I find that people are not doing the thing because they're struggling to organize it. Or like I said, they're, fearing the boredom. There can be a really strong relationship with avoidance here rather than just like refusing to comply. And then resistance. I want to just take a moment here with difficulty with change. I have an autistic friend who I asked once, how do you explain sudden change to neurotypicals? And she was like, I can't. Like, I tell them that I physically cannot, and then I don't know how to explain myself past that. For a lot of us, sudden changes or changes in routine or setting can be physically painful and physically exhausting. For a lot of us, there's a lot of sensory experience that comes with this, and that's the best explanation I've got. I'm still working on it, so maybe check in next year. But this is something to be really aware of. Is it may not be resistance or fighting the therapy itself. It may be the challenge with changing, even if it's changing habits and a fear of what might come with that, which I know is very human. But this is a big, big feature for us. And then some resources for you to be aware of. I'll go ahead and get this whole list up here just so you have it. Attitude Mag is an online resource devoted to ADHD, and they have a lot of really helpful articles. Dr. Hallowell has done some writings for them. I do want to just give you a caution. They had a couple of kind of pseudo-scientific articles that popped up this last year, but I think there were some changes and I haven't seen those more recently. They have some great articles around, the ADHD community refers to it as rejection-sensitive dysphoria. I don't necessarily use that term with my clients, but we do talk about sensitivity to rejection, and they have great resources for that. Driven to Distraction by Ned Hallowell. And I forgot to add John Rady up there, so I apologize to Dr. Rady. But Dr. Hallowell is a psychiatrist who treats ADHD, who has ADHD. And so Driven to Distraction is a great tool with that kind of dual perspective. He wrote a list of proposed criteria for ADHD that's a lot more comprehensive and includes a lot of these soft features that I've been talking about. I often will review that list explicitly with clients and have them check what resonates with them, because it can really facilitate the much bigger conversation about what ADHD is. Another resource that I'm a huge fan of is the How to ADHD channel on YouTube. Jessica, the gal that runs it, has ADHD, is very excited, and is very open. She also does a really great job of checking the facts with experts before she makes claims, so that it's not necessarily just anecdotal evidence. She really tries to make it educational and well-informed. She has a fantastic bullet journal guide that I recommend all the time, which brings me to bulletjournal.com. Bullet journaling is essentially a planner, but not. It allows us to build a planner around our own structure and around what makes sense for us. It just has to have some common elements like task migration to make it effective. And so the reason that you're looking at my nice white grid paper slides with checkboxes that are color coded is because you've actually been looking at the basic structure of my own personal bullet journal. I have shared this with clients. I have an example bullet journal as well, so that they can start looking and picking what feels effective for them. A lot of clients will look at this particular structure that you're looking at and be like, oh yeah, that makes a lot of sense. I like it. Some of them will look at it and say, I hate it. And they'll go and build one and show it to me. And internally, I'm like, oh my gosh, that doesn't make sense to me, but it makes sense to them. And it works for them. And that's the whole point of the bullet journal, is to provide that flexibility. Another one, ADHDDD.com. She does amazing, Danny is her name. She does these really amazing comics about ADHD. She has ADHD. It can be a lovely source of validating humor for our clients and for ourselves. CBT for Adult ADHD by Mary Solanto is great. The one caveat that I have with most of the CBT materials is that they still lean on terms like inattention. So that's just something to be mindful of. Our group that we are getting started, if you have clients that are interested, which there's no obligation, obviously, but there's a link on our website that they can follow to fill out a form and register. And then some really great resources for kids. On Task in a Box. It's a little bit pricey, but it uses self-monitoring and video modeling in one kind of packaged format that's really easy to set up and teach, and can be a really helpful school resource for building attention regulation over time. Some resources for parents and teachers, Barkley and the Tough Kids series by Jensen and colleagues. I apologize, I don't have all the names memorized. Those are really great resources. They're very, very behaviorally focused. And so I often will coach parents about, implementing these things consistently and really applying these principles. But keeping a lot of reliance on their own warmth as well. It's really important that those two things come together. And then the last one is rightslaw.com. These guys, this is a huge case law blog around special education. They have a really comprehensive guide for 504s and IEPs. Which even if you're working with a gifted client who is a student, there is a strong possibility that they could still benefit from a 504. That's a twice exceptional is the term that comes up a lot there. And so being knowledgeable about these things can be so helpful for your clients, because getting started with navigating that system can be really overwhelming and daunting. And so being an advocate can be so, so powerful. And then some questions that came in. I love this question so much, and I want to validate the person that sent this, because often we underestimate the overlap that can occur between these two things. This I take on a case-by-case basis, and I'll give you the psychology answer of it depends. But if I have my druthers in this kind of situation where I'm looking at ADHD and childhood trauma, I dig in as much as I can into developmental history, school and academic history, trauma history, and symptom history. And in these kinds of cases, I've a number of times actually drawn out a timeline, because I'm visual, and laid things out in front of me to say, okay, this started here, this corresponds with this, and really, really dug in as deeply as possible. This is also where that best practice comes in handy. With individuals where I'm trying to make this differentiation, I get really curious how they do on neuropsych measures like the DCAFs. Let's see, incorporating stimulant treatment with behavioral interventions. I think I talked a little bit about that in relation to sleep. One of the other things that I want to say about this is that the medication crash from stimulants is real. And very often, the place where a behavioral intervention is most likely to fall apart is when the stimulant crash is happening. And so we do a lot of coping ahead, a lot of positive reinforcers, a lot of scheduled breaks, because the medication crash is a special kind of cranky and a special kind of tired, where it's really, we got to survive that 30 to 60 minute period, and then that behavioral intervention is more accessible again. Let's see, preferred way of including parents or families in ADHD treatment for teens. Very often, I defer to the teen as much as I can. Motivational interviewing to build their willingness to include their families is really important. Like I'll do psychoeducation around the fact that to get skills to generalize, we have to practice them in multiple environments. And bringing them to a new environment alone makes them way less likely to generalize. And that kind of psychoed can help to get the teen on board of like, okay, I might need to ask for help for this. It really depends on how that relationship is doing, which I think, yeah, that goes to this next question. Skills for supporting families if frustrations creating family friction. If there's a really high degree of family friction, I try to catch the kid or the parents individually, either for individual therapy or parent coaching, and then refer to a colleague for the other need. And the reason for that is just that I don't want to be the goalie or the in-between. We've got to work directly on the friction as we're building those behavior management skills, or the behavior management can actually be iatrogenic. And then the last question that I got, I wanted to honor with an Eisenhower matrix, or clinician's Eisenhower matrix, which is, what do I wish parents and clinicians understood? All of this. There are no silver bullets. That's so crucial. It's really common for these very concrete brains to walk into my office and say, okay, give me the set of skills and I'll be good to go. And I say, no, it is more complicated. There's not one skill that's going to quote unquote fix you. And if we're here to fix you, then we are not aligned. And so being really explicit about, this is building a toolbox, not turning you into a Swiss Army knife. This is about building a set of skills that you can select from at a given time based on what your need is. And also really prepping and coping ahead for the fact that skills rarely stick, that like we learn these things over time and they become habits, and we learn them and set them down and pick them back up, and that's normative, because with the concrete nature of this population, it's pretty common to learn the skill, set it down, and then be angry that that's what we did. So let's see. I just wanted to point out those things are myths. Chuck them and throw them away. Let's see. And then there's references if anybody's interested. I think we have about 4 minutes left. Thank you for putting up with me talking so fast. I think we have a couple of questions that came in through the Q&A. Let's see. I'm going to go ahead and stop sharing the slides so that I can see what those questions are. I will do my very best. Let's see. Sorry, I have a couple of different chat windows to look through. Oh, CBD oil with results for ADHD. Good question. Oh, I have a lot of feelings about this one. The main reason for that is that it goes a little bit back to the silver bullet thing that I was talking about, where when people, in the things that I've seen where they say it works, it's that kind of attitude. To my knowledge, there is emerging support that it can help with some of the anxiety associated with ADHD, which does exacerbate the symptoms, but I don't know of anything confirming it as being directly helpful for ADHD. Let's see. What have I seen with adults with ADHD affecting marriages? Oh my gosh, I love this question so much and want to add the caveat that I am absolutely not a couples counselor. So I'm going to be less acquainted with some of these issues. Driven to Distraction has I think it's a whole chapter actually about the relationship between ADHD and sex life in a marriage. In the question, they have feeling bored or stagnant in their marriage and causing them to question compatibility or it being their desire for stimulation. 100%. I'm so glad that you framed it that way. That's exactly how I would have answered, is yes, it can lead to this sense of stagnation. I do know that there's some research that infidelity is quite a bit higher among ADHD folks, and a lot of it goes back to that stimulation seeking and impulsivity. Let's see. What do I recommend for ADHD clients who have substance use issues and cannot take medication? Good question. I also am not explicitly a substance abuse counselor. I would say that by the time clients get to me and there have been substance use issues, they've got it at a level where they've been through detox or they're self-managing fairly effectively-ish. Integrating ADHD psychoed can be really helpful. We'll do a fair amount of behavior chaining around this and integrate like, hey, is this that impulsivity showing up? And what was the relationship between you and boredom when the urge to use came in? I think with the social factors, that can also be a real challenge where if there's that kind of context of fearing rejection as a contributing to feeling pressured to continue using, that would be something to think about as well. I'm sorry, that's kind of I'm not sorry, that's a collage-y answer. That's the best one I've got for you. Let's see. I think that's all the questions that have come in so far. For my clinical support staff, were there any others that we wanted to look at? Okay, I think that's all we had for questions. If you do have clients that might benefit from the group, feel free to visit our website. It's ucebt.com/events. The plan is we're going to meet twice a week for 4 weeks, and that twice a week purpose is really to help facilitate behavior change, including reducing self-judgment and increasing self-compassion. So feel free to contact us as well if you have any questions.